Welcome back to Rad-On Smart Review.
Hello.
Today, we are locking the doors and turning up the heat. We're focusing on the head and neck edition, specifically the Oropharynx Capstone.
Right.
But we aren't just going to review papers. We're going to simulate the environment that keeps every resident awake at night.
The oral boards.
The oral boards. I'll be playing the role of the examiner, the senior attending running the room.
And I'm stepping into the hot seat. I'll be playing the role of the examinee. The resident who needs to keep it cool, structure her thoughts, and hopefully pass the exam.
Exactly. This is a simulation. We're going to move through 5 specific clinical blocks. These are longitudinal cases. They'll escalate from workup to staging, treatment, and planning.
Okay.
But to simulate real pressure, in every block, I'm going to throw you a twist.
A twist.
A sudden change in the clinical picture or pathology that forces you to pivot your decision-making immediately.
I'm ready. The key here for everyone listening is that the right answer depends entirely on the specific details you give me. I'm going to focus on verbalizing my structure, showing my work, not just, guessing the answer.
Perfect. That's the goal. No long preambles today. We're going straight into exam mode.
Let's do it.
Take a deep breath. Let's begin block 1.
Right.
You have a 52-year-old man presenting to your clinic. He has a 2-week history of a painless right neck mass.
Okay.
He's a never smoker, drinks socially, maybe a glass of wine at dinner, and has no major comorbidities. Performance status 0.
Got it.
On your physical exam, you palpate a distinct, firm 3-centimeter lymph node in the right level 2 region.
Okay, level 2.
You perform a fiber optic scope, and your oropharyngeal exam reveals a 2-centimeter exophytic mass. It's centered in the right tonsillar fossa.
And its relation to the midline.
Does not cross the midline. The soft palate is minimally involved. The left neck is unremarkable.
Okay, I have the picture.
Question 1. Before we get into the cancer itself, I want you to define the key anatomic boundary between the oral cavity tongue and the oropharynx. Then explain to me why HPV status matters in this specific site.
Okay, so the practical anatomic boundary we're looking for is the line of the circumvallate papillae and the foramen cecum region.
Right.
This is the crucial dividing line. Anything anterior to that, the mobile tongue, is considered the oral cavity. Everything posterior to that line, including the base of tongue and the tonsils, is oropharynx.
And why does that distinction matter?
Well, it dictates the biology and the staging. Regarding HPV status, it's absolutely critical because P16 positive oropharyngeal cancer represents a distinct biological entity compared to, traditional smoking-related cancer.
In what way?
It has a significantly better prognosis. It's also more sensitive to radiation and cisplatin. And because of this, the AJCC 8th edition created a completely separate staging system for P16 positive disease.
And what's the effect of that new system?
It generally downstages patients compared to the HPV negative classification. And it's important to note that P16 status doesn't drive staging or management for true oral cavity cancers anterior to that line in the same way.
Correct. And here's the teaching pearl for everyone listening. Say circumvallate papillae confidently.
Right.
Don't mumble it. It shows you know your anatomy. And then immediately pivot to the biological difference. The examiners want to know that you understand that anatomy dictates biology here.
Understood. Anatomy is destiny.
Moving on, you perform a biopsy of the tonsil mass. It confirms squamous cell carcinoma, and P16 is strongly positive.
Okay.
You order an MRI, which shows the primary is confined to the right tonsillar fossa with that minimal soft palate involvement we saw. But, and this is key, there's absolutely no posterior pharyngeal wall involvement.
Okay, that's important.
You also get a PET-CT scan. It shows a single FDG avid ipsilateral right level 2 node measuring 3 centimeters, no distant disease, no radiographic extranodal extension. Question 2. Stage this patient using the AJCC 8th edition.
Okay, this is an HPV-mediated P16 positive case. I'll start with the T stage.
Right.
The primary tumor is 2 centimeters. T1 is less than or equal to 2 centimeters, so technically it's T1.
Let's call it a T2 for the sake of argument. Say it's 2.1 centimeters on the MRI.
Perfect. So T2. Now for the node, this is where the HPV staging is unique.
How so?
He has a single ipsilateral node that's 3 centimeters. In the HPV-mediated system, one or more ipsilateral nodes, as long as they're all less than 6 centimeters, is defined as N1.
Okay.
There were no metastases, so M0. Therefore, we have clinical T2, N1, M0.
And the group stage?
that groups as stage 1.
Correct. This is a stage 1 cancer.
It always feels strange saying that for a patient with a 3-centimeter neck mass.
That's exactly the point. And the teaching pearl here is crucial. Do not equate stage 1 in HPV-positive oropharynx with tiny or insignificant disease. You can have substantial nodal burden and still be stage 1 or 2 because the cure rates are so high. Always state the anatomy and TN categories clearly before giving the group stage. Show you understand the components.
Right. Don't just jump to the number, build the case.
Now, for the critical decision, we need to define your treatment volumes. This is a controversial area. Do you treat the ipsilateral neck only, or do you mandate bilateral neck radiation? Walk me through your logic and your specific criteria.
For this specific patient, I would recommend ipsilateral-only radiation. However, I need to justify this with a strict checklist.
Oh.
My logic is based on the fact that he meets all the criteria for a well-lateralized tonsil cancer.
What are those criteria?
First, the primary tumor is well-lateralized.
Yeah.
You stated clearly there's no midline extension.
Mm-hmm.
Crucially, you stated there is no posterior pharyngeal wall involvement.
Mm-hmm.
The posterior wall has rich crossing lymphatics, so if that's involved, you can't safely omit the other side.
Right.
What else? Second, the soft palate extension is minimal and doesn't approach the midline or uvula significantly. And third, the nodal disease is strictly unilateral with no suspicious activity on the contralateral side on the PET-CT.
So because he meets that checklist?
Yes, because he meets this checklist, well-lateralized, no posterior wall, unilateral nodes, ipsilateral treatment is appropriate.
And why do we prefer it?
To reduce toxicity. By sparing the contralateral parotid gland and the contralateral constrictor muscles, we significantly reduce long-term xerostomia and dysphagia. It's a quality-of-life decision that doesn't compromise oncologic control in properly selected patients.
Excellent. That is the board-winning answer. It's a win-condition checklist. You didn't just say it's on the right side. You specifically ruled out midline extension and posterior pharyngeal wall involvement.
Right.
If you don't say posterior pharyngeal wall, you haven't fully justified the safety of the plan.
Got it.
Next question. What concurrent systemic therapy do you recommend? And I want you to specifically address cetuximab.
The standard of care is concurrent cisplatin with definitive radiation.
What's your regimen?
My preferred regimen would be high-dose cisplatin, 100 milligrams per meter squared, given every 3 weeks for 3 cycles. So on days 1, 22, and 43. The goal is a cumulative dose of at least 200 milligrams per meter squared.
Any alternative?
Well, weekly cisplatin at 40 milligrams per meter squared is an acceptable alternative if bolus dosing isn't feasible, due to logistics or minor concerns, but high dose is the classic Category 1 recommendation.
And cetuximab?
I would specifically not use cetuximab as a substitute in this patient.
Why not?
We have large randomized data, specifically the TOG 1016 trial and the de-escalate trial. These studies demonstrated that cetuximab is inferior to cisplatin in HPV-positive oropharynx.
Inferior how?
It showed inferior overall survival and inferior locoregional control. And furthermore, it didn't provide a meaningful reduction in severe toxicity. It just traded renal toxicity for severe skin reactions. So unless there's an absolute contraindication to cisplatin, cetuximab should not be used.
Correct. Cisplatin is standard, cetuximab is inferior. That's the phrase you want to have locked in.
Okay.
Now, describe your radiation dose and volumes for a definitive IMRT plan in this ipsilateral approach. Be specific with your prescription.
I would use volumetric modulated arc therapy, or IMRT, with the simultaneous integrated boost technique. For the high-risk volume, the PTV70, this includes the gross tumor volume of the primary and the gross lymph node.
And the dose.
I would prescribe 70 grays, the 35 fractions.
And the elective volumes.
For the intermediate or high-risk elective volume. So that includes the ipsilateral consular fossa clinical target volume and the involved nodal level with a margin typically levels 2 through 4. I prescribe about 60 to 63 gray.
And low risk.
For the low-risk elective volume, covering the remainder of the ipsilateral elective neck, I would prescribe 54 to 56 gray.
Is there any specific nodal group you need to be careful to include, even in a unilateral plan?
Yes. The retropharyngeal nodes.
Explain.
Even for an ipsilateral plan, I would explicitly include the ipsilateral retropharyngeal nodes in the treatment volume, given the presence of ipsilateral level 2 nodal disease. I would omit the contralateral neck and contralateral retropharyngeal nodes.
Good. You mentioned the retropharyngeal nodes. That's a vital detail. Even in an ipsilateral plan, you must account for the ipsilateral retropharyngeals because they're a primary drainage route from the tonsil.
Right.
Now, name your top normal tissue priorities and give me the board-safe dose constraints you aim for.
My top priorities are preserving the parotid glands and the swallowing structures. For the parotid, specifically the contralateral parotid, which we're sparing completely, I aim for a mean dose of less than 26 gray. In this case, it should be essentially 0. For the pharyngeal constrictors, I aim for a mean dose of less than 50 grays to the structures not involved by the high-dose target.
What else?
For the larynx, I aim for a mean dose of less than 44 to 50 gray. I would also limit the cochlea to a mean of less than 45 grays, especially given the use of cisplatin.
And the cord.
And the spinal cord maximum is limited to 45 to 50 gray.
Correct. The anchors are parotid mean less than 26 and constrictors mean less than 50. Memorize those specific numbers.
Got it. 26 and 50.
Now here's the twist.
Okay.
We have the same patient, 52 years old, T2 and 1. But you dig into the history and find he has moderate baseline sensorineural hearing loss from a previous job in a factory. You check his labs, and his eGFR is found to be 45. How does this change your management?
Wow. Okay, this changes the landscape significantly. He now has relative, if not absolute, contraindications to cisplatin. The hearing loss puts him at risk for deafness with cisplatin, and an eGFR of 45 makes high-dose cisplatin dangerous. I mean, we're talking about permanent renal failure. I can't just proceed with standard high-dose cisplatin.
So do you switch to cetuximab?
No, that's the trap. My first move is to reevaluate the treatment modality entirely.
What do you mean?
I would pause and consult with my head and neck surgery colleague to evaluate him for transoral robotic surgery, or TORS.
Why surgery now?
Because if he's a candidate for TORS and a neck dissection, he might be able to avoid chemotherapy altogether.
Right.
If the pathology comes back favorable, he might only need adjuvant radiation alone. This completely avoids the nephrotoxicity and ototoxicity of cisplatin.
And if surgery isn't an option?
If we must stick to a radiation-based approach, I would consider weekly cisplatin with strict audiometry and renal monitoring, or potentially a non-cisplatin regimen like carboplatin fluorosil, though the data is older.
But not cetuximab.
I would explicitly counsel the patient that cetuximab is an inferior option regarding cancer control and would only use it if every platinum option is absolutely ruled out.
Precisely. The win condition here is to recognize that when the drug is the problem, you change the modality, not just the drug. TORS is the best way to navigate around cisplatin ineligibility.
Reevaluate the modality. Got it.
Let's move to Block 2.
Pretty.
Block 2, HPV positive base of tongue with bilateral disease. Here's your patient. A 58-year-old man presents with 2 months of dysphagia.
Okay.
He's a remote smoker with a 10-pack year history, but he quit 15 years ago. On exam, you see a base of tongue mass that clearly crosses the midline.
Crosses midline. Yeah.
The PET CT shows a large 5-centimeter FDG avid primary at the base of tongue. In the neck, there is bilateral level 2 adenopathy. The right node is 4 centimeters, the left node is 2 centimeters. Biopsy confirms P16 positive squamous cell carcinoma, no distant disease.
Okay.
Question 1. Why does a base of tongue primary generally mandate bilateral neck treatment?
It comes down to anatomy and lymphatics. The base of tongue is a midline structure.
And that means?
It has a rich, bilateral lymphatic drainage network that crosses freely. Even if a tumor appears lateralized on a scope, the risk of occult contralateral spread is significantly higher than in the tonsil.
And in this case?
In this patient's case, the tumor physically crosses the midline, so there is no debate. But even for a lateralized base of tongue cancer, the standard of care is to treat bilateral necks because the failure rate in the untreated neck is unacceptably high.
Correct. Base of tongue equals bilateral neck. Keep it that simple. Question 2, stage this patient.
Okay, this is HPV mediated. The primary is 5 centimeters. Since it's greater than 4 centimeters, it's T3.
Nodal stage.
The nodal disease is bilateral. However, all nodes are less than 6 centimeters. In the HPV staging system, the presence of contralateral or bilateral nodes defines N2. So, clinical T3, N2, M0.
And the group stage?
T3, N2 groups as stage 2.
Correct. It is stage 2. Again, notice that a 5-centimeter tumor with bilateral neck disease is still technically early stage grouping, but the tumor burden is significant.
Right.
Now, question 3. Do you cover the retropharyngeal nodes in this case?
Yes, absolutely. The risk of retropharyngeal involvement increases with base of tongue primaries and significantly increases with the presence of bilateral level 2 adenopathy.
So what's the plan?
I would treat the bilateral lateral retropharyngeal nodes, typically starting from the skull base down to the upper cervical region or hyoid bone.
Good. You must explicitly say yes to retropharyngeals here. If you miss that, you miss the safety margin.
Understood.
Question 4. What is your concurrent chemo plan? And specifically, how do you approach swallowing protection in a bilateral plan?
My systemic plan remains concurrent cisplatin, aiming for 200 milligrams per meter squared cumulative.
And the swallowing protection?
That's much more challenging with bilateral neck treatment than with a tonsil case. I'd prioritize sparing the pharyngeal constrictors that are not involved by the tumor, likely the inferior constrictors, aiming for a mean dose of less than 50 grays where feasible.
What else?
I would also strictly limit the dose to the larynx and avoid unnecessary dose bath to the oral cavity and anterior oral mucosa to prevent mucositis.
What do you tell the patient about swallowing?
I counsel him that dysphagia is expected. I ensure aggressive supportive care, including pain management and nutritional support, because avoiding treatment breaks is a critical part of the strategy.
And why is that so critical?
A break in treatment allows tumor repopulation, which worsens outcomes.
Correct. Minimizing breaks is part of the swallowing preservation strategy because breaks lead to worse outcomes. Now, here's the twist for block 2.
I'm listening.
You start treatment, everything is going well. But after cycle 2 of cisplatin, so he's received about 200 milligrams per meter squared, the patient's creatinine spikes. His eGFR drops to 35. He has acute kidney injury. He's received a cumulative dose of 200 milligrams per meter squared. It is day 43, and he is due for his 3rd cycle. What is your immediate management?
My immediate management regarding the radiation is to continue without interruption.
Good.
I would never break the radiation course for chemotherapy toxicity unless the patient is medically unstable. However, regarding the chemotherapy, I would hold the 3rd cycle of cisplatin.
Why stop? Why not switch drugs?
He's already received 200 milligrams per meter squared. This is widely considered a therapeutic threshold for efficacy.
Explain that.
The data suggests that the benefit of cisplatin is achieved largely by reaching this 200 milligram mark. Given the acute kidney injury with an eGFR of 35, giving more cisplatin is unsafe and could cause permanent renal failure.
So what do you do?
I would manage the AKI with fluids. I would not switch to cetuximab for the last dose. There's no evidence to support mixing regimens, and the benefit of a 3rd dose after reaching 200 milligrams is minimal compared to the risk.
Outstanding answer. Radiation continues, chemo adjusts, and you recognize that 200 milligrams is the magic number.
Right.
Once you hit that, you can declare victory on the chemo front if toxicity arises. Don't try to be a hero and push for 300 if the kidneys are failing.
Right. Save the kidneys, finish the radiation.
Exactly. Let's move to block 3.
Okay.
Block 3. HPV negative oropharynx. This is the poor prognosis scenario. A 64-year-old man, heavy active smoker, heavy drinker. He presents with severe throat pain and referred-talgia.
Okay.
Exam shows a large 4.5 centimeter ulcerated mass on the right tonsil extending onto the soft palate and the lateral pharyngeal wall. In the neck, there's matted adenopathy in levels 2 and 3 with clear radiographic extranodal extension, or ENE. The biopsy is P16 negative.
Okay, so a very different patient.
Very different. Question 1. Stage this using the AJCC 8th edition for P16 negative disease and contrast it with how this would look if it were positive.
Okay. For P16 negative oropharynx, the staging rules are different. They follow the more traditional size and invasion criteria. The primary is 4.5 centimeters. Since it's greater than 4 centimeters, that's T3.
Not T4.
It's not T4 unless it invades deep structures like the mandible pterygoid muscles or in cases the carotid, which wasn't described.
Correct.
For the neck, he has matted nodes with clinical extranodal extension. In the P16 negative system, the presence of clinical ENE automatically escalates the end stage to N3B.
Okay, so T3, N3B.
Yes, T3, N3B, M0.
And the group.
NET with N3 disease groups as stage 4B.
And the contrast with HPV positive.
If this were P16 positive, the clinical ENE would not drive the end stage up to N3B in the same way. The clinical staging system for HPV positive disease is much more forgiving of nodal burden and ENE. This patient would likely be a lower stage group if he were HPV positive.
And the prognosis.
As an HPV negative stage 4B, he has a very poor prognosis.
Exactly. Don't fall for the trap of calling it T4 just because it looks ugly on the soft palate. T4 requires invasion of bone or deep muscle. And recognize that stage 4B in HPV negative is a very different beast than the stages we discussed earlier.
Right.
Question 2. How do you counsel him on prognosis, and is there any role for de-escalation here?
The prognosis is guarded. HPV negative disease has significantly higher rates of local regional failure and lower overall survival compared to HPV positive disease. I would counsel him that this is an aggressive cancer requiring aggressive treatment.
And de-escalation.
Absolutely no role for de-escalation.
Mm.
All the de-escalation trials are predicated on the favorable biology of HPV. The standard of care is full dose definitive, IMRT to 70 gray, with concurrent high-dose cisplatin.
Good.
I would emphasize smoking cessation to improve his response, but I would not modify the treatment intensity.
Correct. No de-escalation in HPV negative disease. That is the rule.
Okay.
Here's the twist for block 3. You get the final pathology report back from the biopsy, you check the histology, and the pathologist notes that it is a basiloid squamous cell carcinoma. You see that word, basiloid. Does this histologic variant change your management plan?
No, it does not.
Yeah, sure.
Yes. While basiloid squamous cell carcinoma is known to be an aggressive variant of squamous cell carcinoma in the setting of locally advanced oropharyngeal cancer, the management is driven by the stage and the HPV status. It's still treated as a squamous cell carcinoma.
So what's the plan?
I would proceed with the standard definitive chemoradiation plan to 70 gray with cisplatin. I would not alter the dose to something higher, nor would I change the drug based solely on the basiloid adjective.
Correct. Don't let adjectives distract you. Anchor to the stage and the biology. Treat it as standard locally advanced SCC.
Got it. Standard of care prevails.
Moving on to block 4. This is a surgical case.
Okay, shifting gears to surgery.
A 48-year-old patient with a P16 positive right tonsil cancer. He undergoes transoral robotic surgery, TORS, and a right neck dissection.
Okay.
The pathology report comes back. PT1 primary. Margins are negative, but close 2 millimeters. In the neck, there are 3 positive lymph nodes. Largest is 2.5 centimeters.
Okay, 3 nodes.
However, the pathologist notes extranodal extension present, measuring 0.8 millimeters. Lymphovascular invasion, or LVI, is present. Question 1. I want you to use the E2311 trial framework. Classify this patient's risk and recommend adjuvant therapy.
Okay, using the ECOG 3311 framework, I need to bucket this patient into low, intermediate, or high risk.
Go ahead.
The criteria for intermediate risk in that trial included having 2 to 4 positive nodes or having minimal extranodal extension, which was defined as less than 1 millimeter.
Does he fit that?
Yes. He has 3 nodes, which fits the 2 to 4 criteria, and his ENE is 0.8 millimeters, which fits the minimal ENE criteria. So he is intermediate risk.
What is the recommendation?
My recommendation would be adjuvant radiation therapy alone. I would not add concurrent chemotherapy.
And why not?
The E2311 trial, it validated that these intermediate risk patients have excellent outcomes with radiation alone, sparing them the toxicity of cisplatin.
Excellent. You picked up on the minimal ENE concept. In the old days, any ENE meant chemo, but in the HPV-TORS era, less than 1 millimeter allows you to omit chemo. That's the teaching point.
Right.
Question 2, what dose do you prescribe? 50 gray or 60 gray?
Well, both are defensible within the context of the trial, as intermediate risk patients were randomized between 50 gray and 60 gray.
But what would you choose?
Given the multiple risk factors here,
Yeah.
he has 3 positive nodes, LVI, and the ENEs present even is minimal. I would lean towards 60 gray to the surgical bed and involve nodal levels.
Your reasoning.
50 gray was the experimental arm for the low intermediate risk, but with these multiple features stacking up, 60 gray is a very standard safe answer.
I agree. 60 gray is the safer board answer when you have a stack of minor risk factors like that. Now, here is the twist. The pathology report is amended. A second review measures the extranodal extension again. They revise the measurement to 1.2 millimeters. Does this change your plan?
Yes, it changes everything.
Yeah.
1.2 millimeters exceeds the minimal ENE threshold of 1 millimeter. This moves the patient out of the intermediate risk category and into the high risk category.
So what's the new recommendation?
With frank ENE greater than 1 millimeter, the standard of care reverts to post-operative concurrent chemoradiation. I would recommend 66 gray to the high-risk areas with concurrent cisplatin.
Ideally stated, the 1 millimeter cutoff is hard. Once you cross it, you're back in high-risk land, and you must add the chemo. It seems like a tiny difference, but the protocol is strict.
Understood. 1 millimeter's tipping point.
Exactly. Let's move to our final clinical scenario.
Right.
Block 5, recurrent oropharynx.
The salvage case.
Correct. A 55-year-old man. He had a P16 positive base of tongue cancer treated 18 months ago with definitive chemoradiation 70 gray and cisplatin. He did well, but now surveillance imaging and biopsy confirm a local recurrence at the base of tongue. It's 2 centimeters in size, no distant disease.
All right.
Question 1. What are the factors that determine if he is a candidate for curative intent salvage?
Okay, I need to run through a rigorous selection checklist. First, the disease-free interval. 18 months is a reasonable interval. A recurrence within 6 months would be a very poor prognosis.
Resect.
Second, resectability. Can the surgeon clear the disease with negative margins?
Mm.
Third, baseline function. Is he dependent on a G-tube or a track? If his function is already destroyed, salvage surgery might be devastating.
And last.
Fourth, tumor volume and extent. So does it involve the carotid artery or prevertebral fascia? And finally, distant metastasis. I have to rule out distant spread before attempting local salvage.
Perfect. Interval, resectability, function, volume, carotid metastasis. That's the checklist.
Right.
Now, question 2. The tumor board decides he is resectable. He undergoes surgery and achieves negative margins. Do you recommend adjuvant reirradiation?
This is a nuanced decision. It is not automatic.
So what's your answer?
Since he had a clean resection with negative margins, observation is a very reasonable standard of care. Re-radiation in the head and neck carries a high risk of severe late toxicity. Carotid blowout, soft tissue necrosis, osteoradionecrosis.
So you wouldn't do it.
If there were positive margins, or frank ENE in the recurrence, the argument for re-irradiation would be stronger. But with negative margins, I would favor observation and reserve re-irradiation for a future problem, or offer it only after a very thorough discussion of the high risks.
Correct. The teaching pearl is re-irradiation is not mandatory after a clean salvage. It is a high-stakes gamble. Often, the best adjuvant therapy after clean salvage is careful observation.
Okay.
Now, the twist for block 5.
Right.
Before you take him to surgery, you get a PET CT. It shows the recurrence at the base of tongue, but it also lights up a new FDG avid lesion in the left piriform sinus in the hypopharynx. What is your next step?
My next step is to stop and biopsy the new lesion. I cannot assume I know what it is. It could be a second primary, it could be a multifocal recurrence, or it could be a metastasis.
Yeah.
It dramatically changes the surgical plan. A base of tongue resection is very different from a total laryngopharyngectomy.
So
I need tissue confirmation before we plan any massive salvage procedure.
Exactly. Never assume. A second lesion is a hard stop. You must get tissue.
Biopsy first, plan second.
Precisely. You have survived the clinical blocks. Now we are going to finish with the rapid recall pearls blitz.
Okay, bring it on.
I am going to name a trial or a concept. You give me the key takeaway and then the board-safe sentence that summarizes it. Ready?
Ready?
Topic 1. RTOG0129.
Takeaway. HPV status is a dominant prognostic factor. Board-safe sentence. HPV-positive patients have better survival than HPV-negative, but smoking and high nodal stage worsen outcomes even in HPV-positive disease.
Topic 2. RTOG1016 and de-escalate.
Takeaway. Cetuximab is inferior to cisplatin. Board-safe sentence. Do not substitute cetuximab for cisplatin in eligible patients. It results in worse survival and worse control.
Topic 3. The E3311 trial.
Takeaway. It validated risk-adapted post-op therapy for intermediate-risk HPV-positive disease after TORS. Board-safe sentence. Intermediate-risk patients with negative margins and minimal ENE can be treated with postoperative radiation alone, omitting chemotherapy.
Topic 4. The MACHNC meta-analysis.
Takeaway. The timing of chemotherapy matters. Board-safe sentence. Concurrent chemotherapy provides the survival benefit. Induction chemotherapy generally does not improve survival over concurrent alone.
Topic 5. The ipsilateral versus bilateral neck rule.
Takeaway. Selectivity is possible but strict. Board-safe sentence. Ipsilateral neck treatment is appropriate for well-lateralized tonsil cancers with no midline or posterior wall involvement. Base of tongue mandates bilateral treatment.
Final topic. Dose constraints. Give me the anchors for parotid, constrictors, larynx, and cord.
Parotid. Mean dose less than 26 grays. Constrictors. Mean dose less than 50 grays. Larynx. Mean dose less than 44 to 50 gray. Copley. Mean dose less than 45 gray. And spinal cord. Maximum dose 45 to 50 gray.
Excellent. You nailed the constraints. And that brings us to the end of the simulation.
That was intense, but the structure really helps.
It does, and that's the key to the oral boards. It isn't just about knowing the fact, it's about organizing the fact into a logical answer. You handled the twists well, pivoting from standard chemo to TORS and recognizing when to stop chemo in the setting of AKI. Those are the decisions that show clinical maturity.
Thank you. The E3311 distinction about minimal ENE is definitely something I'll keep in mind.
Absolutely. Knowledge must be applied, not just memorized. To all our listeners, good luck with your study. For more resources, check out radoncsmartlearn.com. And I passed you. Thanks for the session.
Session adjourned.